BBIF Cancer Care was launched in 2024 with an idea to spread cancer awareness
This is in collaboration with BBIF Foundation, and we have been organizing this along with one workshop which was on the first day, that was related to skill building of the medical personnel and focusing on clinical breast examination.
To commend the work of BBIF, I think BBIF as an organization is doing great in terms of creating awareness at the rural masses, as well as connecting connecting the referral services from the rural masses.
INTERONC 2026 is a one-of-a-kind conference with interdisciplinary people from community medicine, oncologists, and clinicians. It's a great way to have an amalgamated session.
And how the science of precision oncology has evolved over the years, especially in the field of breast cancer. So I must compliment Dr. Virender Yadav for having me here today, and it was a pleasure participating in INTERONC 2026.
And I'm pleased to be part of this INTERONC 2026 conference and the pre-conference workshop, which is being organized by BBIFF in collaboration with Department of Community Medicine at Maulana Azad Medical College. This organization is doing a tremendous work in the rural parts of our country, and I applaud them for that. And I also kudos to them for organizing this this conference and pre-conference workshop, for bringing so many experts from across the fields in medical sciences together for 3 days. It's going to be an academy.
And there's a sensory request. Please don't use your nails on bottles. Please be very careful. But when it comes to the question, I have not taken on that's what I said. I totally see the but they will all find it. So this is the normal. And this is it's a small difference. But sometimes it's like I was feeling something like that. That's two particular points. I think no, there's no now, but it's because
is everyone normally जब मामा केयर की ट्रेनिंग होती है, this is an institute based in Florida, यहाँ से लोग ओपन है ट्रेनिंग किए, so they ask you to place it here and feel it. All right now we will just do it otherwise. So please feel for the normal nodularity of the breast. Please don't look at the lumps. Forget about the lumps. कैसा है, कैसा महसूस हो रहा है, सिर्फ normal nodularity. Again, the same, the K hands position, where you will start from the armpit, go down, making vertical strip till the nipple, and with the Opposite hand, we start exactly with the flat finger from the armpit highest point. We go to the nipple. Once you have reached the nipple, what will you do? How will the position change? Can somebody else answer? Somebody else, please. The hand becomes perpendicular and you take the straight up. वापस supine position में आ जाती हो. And then with identify.
Press like this. You're pressing like this. That's why you keep on Here's the examination. Getting out of bed and give best coverage or more complete coverage. No.
Now we have seen supraclavicular and intraclavicular investors has ever had breast cancer. Now if a woman has breast cancer and she does not have a daughter and has a son, you think the son may also be predisposed, may have a higher risk compared to the population risk? Yes, of course. So you have to mention the breast cancer history also. You must have heard of some fancy names like Gale model for prediction of invasive breast cancer in the next 5 years and the lifetime risk of contracting breast cancer. These are some fancy models of epidemiological significance. तो इनमें ये चीजें बड़ी जरूरी होती हैं.
Activities which differ. So unsafe practices, unsafe sexual practices, that will cause delayed healthcare facilities to treat a precancerous lesion before it becomes invasive. All those things combined together to result in the presentation which is usual in our OPDs of having locally advanced cancer cervix walks into our OPDs day in, day out.
Preventable potential. I'll come on to a slide which will show like up to what extent we can prevent these cancers. But that is to emphasize upon you that these are preventable cancer and we can make a lot of impact in our cancer burden in our country with the preventive approaches. And
demonstration research projects funded by national international agencies, ICMR, WHO, UNSW, Australia.
As per the WHO, if a woman undergoes HPV DNA testing twice in her lifetime, at 35 age and 45 age, that is sufficient to, warrant that she will not have cervical cancer later.
Cancer, mouth and pharynx still remains a high burden in our country with the tobacco usage. I think it is high time that all screening methods are pushed to such extent that it becomes a norm that every person visiting a facility has to be screened for certain basic things. And that Dr. Apurva with us. Dr. Apurva is currently a senior research fellow at the Australia-New Zealand Oncofertility Clinical Trials Network. Her present affiliation is with the Department of Obstetrics and Gynecology.
The consequence is not merely biological infertility, but decisional regret, moral injury, and pervasive sense of among survivors that the fundamental aspect of adulthood has never acknowledged at the moment where and when it mattered most during their journey of survivorship.
Either in the stage 3 or the stage 4, and this is one of the key challenges. Highly specialized tertiary care treatment. Yes, cancer required highly specialized treatment. It is not diagnosis or the treatment initiation. It will not be possible at the primary or the secondary.
This program has been again implemented by the Government of India through different channels, but starting at lower down level also the Ayushman Arogya units. Now we see
as well as the timely referral, and beyond the curricular requirements, I would think that all of us should come together, all faculty, people working in such
and also that cancer is still a stigma in our society. Many people would not like to find out that some of their members die of cancer. Like, you have to keep the patient at the heart of all kinds of treatment. And for every protocol that you write, or every research paper that you write, or every discovery that you make, it has to be, a patient at the center. And the journey.
He introduced me to Mr. Vijay and said that I would like to introduce the person who is born of PhD.
And all of this can be done using next generation content. So, modern NGIs today, when we use it in our clinic, is beyond the very classical consultation. So we now evaluate something called homologous recombination repair deficiency. We're looking at methylation signatures, we're looking at tumor mutation burden, we're looking at RNA fusions, we're looking at linear and these layers actually give us functional information about the tumor biology. The DNA repair capacity is telling you the epigenetic identity, the unique fingerprint that is, every tumor has its own unique fingerprint, that's your methylation signatures. We're looking at that. We're looking at real-time tumor burden, and what we're doing is we're moving purely from a structural behavior to the genomic behavior of the tumor.
What the etiology is and the diagnosis, then you can definitely give the management, and the management will include the supportive care as well as the intervention that you might need to do, which could be, as I said, radiation or embolization or endoscopy. For platelets, there's a lot of things we can do. I often find that surgeons are afraid to take a low platelets. There's a lot of support we can do with apheresis platelet, pool platelets, PRP. We can even use injections of recombinant factor 7A. If a patient is on an antiplatelet drug, it's actually okay to keep the platelet count about 50,000. We don't always need to transfuse for a low platelet count. If the patient is not using a platelet count of 20,000, it's actually
scrutiny and promotional structural determinants of the people actually is giving an outcomes injury. They will undergo breast conserving surgery but not come for age. So de-escalation using some techniques like hypofractionation, like intraoperative radiotherapy and elective treatment implant helps us to reduce the duration of treatment that is required for radiotherapy.
Have certain kind of different histological connotations. Now, if you see in your bladder cancer report a name like nested subtype or a micropapillary subtype or a plasmacytoid variant or a sarcopenia variant, that's a red flag because these sites have been documented in various prospective studies to have bad prognosis, and some of them even are indicative of early cystectomy and neoadjuvant chemotherapy. So it's very important that your report is reading certain kind of variation from normal uterine carcinoma and having these kind of subtypes you should give importance to these details. Staging, nothing much has changed in stage 2. It's practically screening. And when we talk about the screening and the surveillance of bladder cancer, cytology is
what about the quality of life? When the survival improves, we are more concerned about what about the organ preservation and also the access to that.
The institute will make sure connected with the national cancer awareness and screening program. This is the first step into cancer screening. I say that how how we are connected with the cancer program. And your point of view, I am saying कि हम वहाँ जाते हैं जहाँ के पेशेंट होते हैं और लोगों से बातें करते हैं. बातें नहीं करते थे कन्वर्सेशन करते हैं. जबकि हॉस्पिटल में क्या होता है कि पेशेंट इज कमिंग टू द हॉस्पिटल एंड दिस सो वी आर having a meeting there, we are connecting, we are having conversation with them, and we are understanding the real part of what is happening to the people over there and in that area. So as you know that we have went to the rural area in the last our time we had there are some of the ladies who had long but they are not aware of the education and you as this is the time to do. So in this way we are going to do the present and to do the report to make them aware so that the video, so the conversation, and also to go the problem or survival. So they will be more connected to in this way. Every one of questions related to this topic is what are the basic challenges we will see and face the mind to the society, especially in rural areas. How do you feel that these are the hurdles where we have to work hard and we have to understand what the story behind is and what planning you make next time when you come with the other preparations to mostly or to clear or to after to say sometimes like how so that what we know that even yesterday of we had breast examination in which they say that we have to do breast examination this way, that way. But what I realized that in village there are very small homes, but they don't have so much space to go on the breast examination. So then we need to reduce the time to do that work. They need to try to do that. Second, we know that even even a lady, when I even first time conversation in our area, when we have to put on, even trying to speak just tell someone that you die, just saying that the bad birthday, but it's the truth that people are going to die. In the same way, if someone has a lump in the rural area, the lady, they are shy to say even to the female that they have something in the breast. So this hurdle I faced first time, but then we went to the second time in that area. People open to come and they will come to discuss that you want to do. So I think that to approach the activity in the area, talk about them, and when we go again, it will be more the whatever the respect restrictions are there. I think that people come more openly to us. Because after this, even the people have the humor. They don't have time and money to go to the different places for the different places. So I think that they need some financial help also, some government hospitals and help also. So people are not aware about the tumor, about where to go. If someone has a tumor, they have only the two place where they will be treated, either the health or the material treatment. They don't know that if they can go to the hospital and the centers where the same support So what ultimately you are going to create or to make awareness in the society? Definitely awareness impacts on the psychology. There are many reasons. First one is related to cancer survival, and second one is the cancer patient who is being cared by the family members or the society. So, Dr. Hassan, what are the psychological impacts when you one owns the patient and the patient needs a psychological or psychological attention? Because once the patient knows that the disease is not going to be cured identical and some socio-economically very unjust, and everybody patient loses the faith, the knowledge, the belief, then the condition becomes worse when patients from society are So one thing of psychological is you feel why you are going to treat and you are going to face the psychological problems to the patient patients are like
there is no hope left for the from the spiritual side also. Now that I'm going to spiritual, you can yes, so time to stress into psychology is going to is how they can still make them at least work for this quality of life instead of quantity of life. So the kind of stress which mind is when I am going to meet the patient or the family is first to make them understand it is not about quantity of life, it is about quality of life. Nobody knows how much daily hours, minutes or seconds we have to our life. When I don't know as a person who doesn't have feelings with me, then why patient or the character who are suffering from a disease, let's say from a doctor patient, how are they categorizing it? Or how are and why are they? They really need to activities days, hours, months, years, or why don't they start living in that particular moment? And why don't they start enjoying their bucket list? Finishing off their bucket list. Because nobody knows what is going to happen there. Maybe there are some instances like doctors have told nothing can be done. It was on their very first visit. But those patients survive for let's say 5 years, 10 years as well. But the first thing which is in communication to them was, let's say, lack of hope or hopelessness. Because nobody knows. Every doctors are telling the patient, physicians are also telling that is on the basis of average of whatever we have treated. So the kind of thing which we do or we can deal with is instilling a hope and not letting them hopeless at any point of time. It's okay if we don't have quantity, but we can still focus on the quality of it and start living in our own presence. Because if I am thinking about too much of my good indicators happened in the past and I need to do self-care, we all feel good about it, but it is again not getting to live in my present. Again, negative impact it has. If I start living in my present, then certainly I'm going to make a better picture.
how this cycle we are to use that again.
So in we are not separating physical health and mental. We have to let people understand that mental health is as important as physical health. If I am there to acknowledge what I am suffering from myself, I am not in the channel, then only I can move forward, accept the situation and do something about it. So we do not have to separate our mental health with physical health. If I have to do something about my own body, I have to be prepared for it mentally also. But doctor only cannot do everything. They are trying to do whatever they can, but I also have to make my own effort. That can only come up when I know what my role would be. So, in spreading awareness about this, that what is their role, what they have to do in their treatment, and how they can help their doctors to deal with it in a better manner.
Okay. When you get the question raised that the patients who take this type of this type of treatment and then sometimes someone saying that why we take this treatment, it's very not. There is a bit about it. There is a bit of my use to your you have to take the you have to take it, and what type of infusion influences the kind of treatment that the body. Thank you.
Everybody knows what to do and what not to do. But as per the researchers feel that during the cancer treatment, diet recommendations I have increased. It's not the balanced diet which would be enough for that. Then we have to give good amount of calories with good amount of high amount of protein. But in Indian scenario, normal Indian person is also not taking a balanced diet. So there's too much of fat diet on internet, there's too much of misconception, all of cultural background. So this is the reason I personally feel every cancer diet is different. For every pet, there is a different kind of diet is required. If a patient is vegetarian, then we have to focus more on the protein, not only on food. But when we talk to the patient, they just thought that there is coconut water is daily, we is healthy, or we have not to take sugar. But when you see the science behind that, all the food whatever in the body is connected to the carbohydrate and sugar. So before is the last thing which you take. So inflammation also is the inflammation from the because when the patients are not getting sugar, they are not getting enough calories, and this is the reason they have got so much of weight. So I personally feel 1-to-1 and enzyme is something is required.
So the patient must be advised proper nutritional care. Now the question that arises, it is not possible at all when the patient is suffering with the incurable cancer like disease in terminal stage, a lot of funds and years borrowed from the society, and is living in a very poor socio-economical status. Then how and what type of remedy you would like to prefer in the high calorie? Can you this ability to ask?
Yeah. So in these kind of issues, I personally feel that we have to encourage our basic home-based diet, because whatever we are eating with your diet, roti, dal, chawal, normal basic this is all equally healthier than fast food or coconut water or drink. So it's kind of issues substitute and would consume practices that say more of that unhealthy things, and they are not concentrating on the home-based nutrition. So this is my
The conventional therapy for the cancer is surgical intervention, then chemo application and radiotherapy. Now it's called anti-tumor. Dr. Vinodji, I would like to know from you. This is a very psycho-impacting conventional therapy of the surgery, especially in breast surgery. The patients will have suffering most of the time to protect the control of the patient and should be there. But sometimes it happens as earlier when the previous session we were listening, the patient was saying that if I know that I have to go to the radiation or chemo, then I have sacrificed my health that much. So what is your opinion when you have to intervene the surgical in this application for surgery, and how much you have to save the control of the breast, and what is the ideal indication where the bleeding comes to you and then you advise your breast will be saved and the results of the test will be.
No, I think we can't work in isolation. It starts right from the beginning where Dr. Virendra will talk about the work of MPs. So the thing is, if they come early, they should be banned with their head. If this is something which cancer, something which is cured. First, if they don't have to afraid the chemo and it's pure evidence to that early. So then it starts from there. And of course, as we said, we did a study on patient providers delay. As you said, the patients are coming late. But we have seen in our study that the provider delays are equally important. By the time the patient presents to some clinician, even a doctor, he didn't know, he gives some antibiotics to them, okay, take some antibiotic, come after 2 weeks, then come after 3 weeks. But by the time the patient gets a proper diagnosis, it's already almost 2 to 3 months delay there. So we can work on that. And coming to your question of breast conservation, I would assure you, there is no way, I think there is, I don't know why people say there is no way where I have offered that I could save your breast and she has saved your breast. If I'm talking about the personal, and there is a one-to-one conversation, and I have to say that this is what happens, this is everything happens. There is no advantage of taking extra tissue. If you are taking the additional margin, there is no advantage of removing your extra tissue from the breast, removing the whole breast. There is no advantage. None of the ladies are saving money. The moment they go out, they come with their husband, and the husband, oh no, it's okay, you take this. I said no, because it's not your body that the tissue should not be used. So most of the time what I do is I have a conversation with the lady one first, I explain everything, and then I bring in relatives and I explain the whole. So it takes twice the time. I think none of the ladies, till now I again vouch for that where I said, I can show you breast, and she said, no, you will do. So that's one thing. I think it's your conviction where you as a surgeon are convinced that your breast conservation is giving her equal result as your marriage or marriage. Secondly, there are situations where there is no guarantee that even if she goes for medication, she will not be chemotherapy is decided irrespective based on what biology of the cancer is. But the radiation, there is no guarantee for most of the hospitals. So there is no guarantee that she will even sacrifice her breast, she will have to do it. So I think these all points should be made very clear by your position with the patient. Thirdly, what I have observed, which will help me in my practice already, I get a photo gallery of the patients with the result. So where I show my patients, see, I've done this procedure, and this is how the outcome is. And she can see, she can decide for herself. I'm very skeptical. I will not give you the perfect breast. Maybe the long, maybe the one is a long. But you will have something in garments, you will have something which is gone, this that is carved, it's a constant reminder in the patient's mind that she has something, she's not normal, she is bubbly. So for a woman, breast is not only a sign of sexuality, it's femininity. So none of the patients convinced if consent properly. I think it's the surgeon's conviction, it's the teamwork which will make patient understand that in certain situations where the cancer is early, there's no advantage removing the breast.
Okay, one supplementary here. I have come to know that after mastectomy, when the chemotherapy was given, and after the age 4-5 years after, there is a phenomenon known as the forgetfulness of the partner's memories. And that is because of the lymphatic process and the brain fog. What is your observation and how do you treat those patients?
So I think the brain fogging period happens because of number of reasons. I think this is the effect of long-term reasons. Then more and more positive development experience. So whenever there is hormonal disturbance
and surgery orthopedic. Amongst we are having a cancer survival. And I would like to request ma'am that what is your experience being a cancer survivor when you were diagnosed as a patient, a victim of the cancer, and then what were the consequences came into life, especially by taking the different types of treatment?
I would honestly say that I as a person, and from all points of view, I think as a community medical person and as a professor in a BT college, so it was my moral responsibility to first of all take a call early, diagnosis, action for early that. So what we need to train all the daily staff, the nurses. So I undertook some training and I got the scholars in the field like Dr. many of our the huge gathering and the take-home message was that we just be anything else. It's like your body can go wrong anywhere. So it's the way you take it, all you know. So if you take it positively and like as it's a compliment and the way you simplify things the way, like you know the molecular side of it, the histopathological side of it. But you cannot tell that, you cannot use that jargon of to the patient. The way my oncologist explained was excellently, and I still remember he just told me you are positive, there is nothing to worry. Yes, you must have read that because I've already read about it. It's a more aggressive form of cancer, and my proliferation AI-C7, which was just talked about by many other academic speakers. It says that it's a higher, it says a proliferation rate, it was on the higher side. But he gave that hope that no, because it's just like locking people. Stages that they are being locked into ER, that is student, this is not much of a unit. So I say he is available. He locked up any time to suppress death by targeted therapy, by there are three options of new therapy, which are and we are talking about the future. And I also got to know about the multi-zone strategy, which they are using now. And of course, the price element. So we have the farm there is a lot of hope. The only thing that by positive, I would say that she should suppress her. So this I think ma'am would agree with me, Dr. Harsha. You rightly told that it's more of a psychosocial aid that you get, and it is not only from the psychologist but your
friends, your colleagues, and of course, your peers.
Especially for the patients surviving. So, in session is towards the team, and at last, I would like to ask everybody just one sentence to each panelist. What is the basic fundamental meaning to establish the holistic approach to our care?
We must treat patients as a whole. Understanding their emotions, understanding what they want, understanding what they like, what they want, and making them understand what they should do.
That's a very when you are about the disease of so unabated awareness is the first thing that is wrong. That is the key.
We stop living our silos where we should start with a team and so that we should not look at a whole other patient, look at patient needs. So that approach, working a team approach, that's the way forward.
In my view, I see that team is created, but there should be a regular meeting in between the teams, and there should be one team. Like one is counseling, one thing, second is counseling, and then like continue around. एक कहता है कि आप खा सकते हो, दूसरा कहता है नहीं खा सकते हो. So I think there should be a regular meeting in between that team, particularly.
Dialogue should be created.
Yeah.
Within the team, dialogue should be created.
One dialogue. Not that one is aligned, but it is not aligned. So one team, one team.
For this approach, we can achieve. Yes.
Navigation for financial regulatory strategy.
Sometimes there would be so manually, I think this was very interesting and this was very having a good experience. We have been here for things, and I would like to thank to our persons who are sitting in auditorium. They are really thankful that this is the 6:15 and very time to go back home. So what are we doing? And
BBIF department should thank all the faculty and also all the CCs and also all the students that participated. Thank you all. Not only me but youngsters. ठीक है ना? जो आपने बाद में काम करना है कैंसर के बारे में जो भी बताने के लोगों को अवेयरनेस तो है ही मस्त है. ठीक है, इतने सारे कैंसर के केसेस है जो कि इंडिया में जो हो रहा है ना, नियरली देखो अभी अराउंड 15 मिलियन केसेस, 1.5 मिलियन केसेस, मतलब 15 लाख ईयरली है ये ऑलरेडी, और अनदर 2045 तक इट विल बी अराउंड 25 लाख पर ईयर. इतना ज़्यादा हो जाएगा. अब मेन पावर तो कम है हमारे पास, इंफ्रास्ट्रक्चर है ही नहीं, है कि नहीं. So this is all up to us to create awareness so that get up and healthy lifestyle जो है अपने मनवाए, और उसके बाद में then they can at least after tobacco, alcohol, healthy lifestyle means obesity reduction, all the healthy diets, ठीक है, and including exercise. ये must है. So you must spread the message, and I hope all of you will continue on doing this all throughout your life, because this is not one time activity. It should happen every time. Thank you all.
Thank you very much. Group photo. साथ निभाना है, कैंसर को भगाना है, कैंसर को भगाना है।